The objectives of my presentation is to review the clinical manifestations of acromegaly and discuss the etiology, diagnosis, and management. So we'll start with a case. A 34-year-old man reports over the last 3 years that he has had aches and pains in his hands and feet, and he recently noticed his hands to have become much larger. How would you screen for, would you first of all screen him for acromegaly? Would you screen that man for acromegaly? Who would screen him for acromegaly? Anyone will screen? Ali? Bashari will not screen? Will screen? Who else would screen him for acromegaly? So this is a real man, actually, a real story. He lives in Dubai. For 3 years, he had these complaints of his aches and pains in his hands and feet. And he would go to his doctor and ask to be, he read, as you know, on Google, and he said, please screen me for acromegaly. And the physicians would not screen him for acromegaly. And the insurance, they will tell him, will not pay for that screening test. So he insisted, and finally, I'll tell you what he did. So if you want to screen, how would you screen? Measure his growth hormone level, measure growth hormone after OGTT, measure IGF-1, do MRI of the pituitary, or no need to screen. The likelihood that he has acromegaly is extremely unlikely. We know acromegaly is very rare. How would you screen? Ali wants C, measure IGF-1. Anyone wants A? What's wrong with A? Measure growth hormone level. Maybe? Okay. But you would agree to screen, and some of you said yes, screen, some said maybe, right? So he got screened, and his growth hormone was 46.7, extremely high. His IGF-1 was 735, and the normal is between 41 and 246. And his visual fields were abnormal, and his MRI showed a large mass, actually partially cystic, in the pituitary, hitting the optic chiasm. You could see it here also. So this man had severe case of acromegaly, and it's not unusual actually that these patients are not diagnosed until 10 years after they present. So we have to have a high index of suspicion for such patients. So if you diagnose him with acromegaly, what is the next step? Do transphenodal surgery, treat him medically with dopamine agonists or somatostatin analog or pegvisomant, growth hormone antagonist, or radiation therapy. Who will go for A, B, C, D, or E? All of these are acceptable treatment recommendations, but the first thing that you need to do is you need to surgically remove the tumor, if you can. So what is acromegaly? It's a disorder marked by progressive enlargement of peripheral parts of the body, especially the head, face, hands, and feet, and it results from excessive secretion of growth hormone. In 1886, Pierre Marie published the first clinical description of this disorder and tagged the name acromegaly in 1886. However, if you go to the literature, it's believed that the pharaoh, Akhenaton, had acromegaly. You could see his features. In Al-Giza, Egypt, also they found the remains of a large adult male, approximately 192 centimeter tall, in his late 20s, and he also had manifestations of acromegaly. So the Egyptians believe that they are the first ones to describe acromegaly. The cemetery was from 2,500 years old. The Italians, however, or the Romans, believe that they are the first ones to diagnose acromegaly. The Emperor Maximinus the Thrax, he used to be called Human Mountain. And he had also, this is a currency coin, he had features of acromegaly. And recently in one of the cemeteries in Rome, they found the remains of what they believe is an acromegalic. The nice thing about this study is they compare his bones to a normal bone. This is his thumb. Look how big the thumb is compared to a normal person. His bones, long bones, and also in his skull, they see that there is a place for a large impression of the pituitary gland. So, Egyptian, Roman, the point is acromegaly is an old disease. And if you look also at the tallest men and women that you can ever find, many of them have also acromegaly. The tallest man in medical history was Robert Pershing Wadlow from Illinois in the US. He was 268 centimeters tall and died at age 22. And you could go actually to that YouTube video and see some of his activities. He was a young man, and all his classmates were really young, and he was the tallest. So what sport did he play? Basketball. So his team used to win all games. And if you look at others, this is the tallest man in the Ukraine with the president of Ukraine, the previous president. And if you look at this man, this is at his marriage ceremony actually. Look at his features. He's 233 centimeters. He's obviously acromegalic. And this is his wedding ceremony, as I said. And this is a basketball player. And look what happened to her. She's in the wheelchair, a tall lady. And look at her face, acromegalic. 2 weeks ago, I was watching a movie and I saw this man, the great Kali. Have you seen any movies for this man? I was watching and I told my wife, freeze. She said, what's happening? I said, take a picture of this actor. He's acromegalic. Look at him. And we read about him, great Kali. He's acromegaly, diagnosed acromegaly. I was with Dr. Bashar Effendi one day, going to the holiday inn in Dubai. We stepped out of the taxi, and the guy who opened the door for us was really tall. And I said to Bashar, look, he's like hypogonadal. I thought of hypogonadism. And Bashar said, he's acromegalic. And truly, he was acromegalic. So Bashar got the diagnosis on the spot. Acromegaloid features are not acromegaly. People look like they have prognathism and some other features, and it's due to, if you evaluate them, they don't have any abnormalities. And the famous picture here is for Leno, who has prognathism. His mandibular bone is long. So, fortunately, acromegaly is very rare. 3 to 4 cases per million is the annual incidence. And there are over 1,000 new cases diagnosed in the US annually. And the prevalence is 38 to 69 cases per million. Male to female ratio is 1. The etiology is mostly from the pituitary, and this was first confirmed in 1909 by Harvey Cushing. And here you see, like this morning, Dr. Peter Trainer said, if you think of Cushing, it's Cushing's disease most of the cases. Similarly, if you think of acromegaly, it's pituitary source in most of the cases. But rarely, you may have peripheral growth hormone secretion from pancreatic islet cell tumors or GHRH secretion from either central or peripheral. So you have to be on the alert for these cases, especially when you do imaging and you don't find a typical lesion, which I had recently, actually, a patient from Dubai who looked full-blown acromegalic. MRI was negative. So now, red flags. Why is the pituitary MRI negative? You need to think about other causes of acromegaly. The pathologic diagnosis after you remove the pituitary tumor has changed recently by WHO classification, and now they subtype them into different subtypes. The most common is the densely granulated. It secretes growth hormone and alpha subunit, and it's likely to respond to somatostatin analogs. The rarer ones is a sparsely granulated tumor and is more resistant to somatostatin analogs. Sometimes you have a tumor that secretes prolactin, so both growth hormone and prolactin, either from the adenoma itself, or you may have mixed somatotroph and lectotroph adenomas together secreting these hormones. Manifestations, they result from central pressure effects of the pituitary mass, because more than 65% are macroadenomas, more than 1 centimeter, so headache, visual field defects, and peripheral actions due to excess growth hormone and IGF-1. Yesterday, Dr. Peter Trainer also showed you the growth hormone physiology. Most of the manifestations of acromegaly are due to IGF-1. Growth hormone also affects the liver with gluconeogenesis, and you get hyperglycemia directly. And the manifestations include periosteal formation of new bone, hypertrophy of joint cartilage, soft tissue hypertrophy, and also hypertrophy of the heart, skin, sweat glands. They have excessive sweating. And of course, they get metabolic dysfunction. You get facial and skeletal disfigurement with mandibular overgrowth, as I showed before. They may get jaw occlusion, overbite, spaced teeth, nasal bone hypertrophy, the voice changes, becomes nasal. So all of these are manifestations. Here you see some of these typical features of acromegaly. They get sleep apnea as well. These manifestations, as I mentioned before, occur extremely slowly over the years, which delays diagnosis by 6 to 10 years. Here you see a classic example from Harrison's textbook of medicine. This lady, 1977, see in 81, she's starting to show some mandibular overgrowth, and here some facial features, and in 88 she has full-blown acromegalic features. When they present, 40% present by chance alone. They are detected by unrelated physical or dental examination. The rest may present with menstrual changes, headaches, carpal tunnel syndrome, like Dr. Samer mentioned earlier, or diabetes. Rarer presentations are shown here, and when you diagnose them with acromegaly, most of them have the acral enlargement or coarse features. Sweating is very common, and these other, and arthritis and carpal tunnel. But that's when you diagnose them, it's a little bit late. Gigantism occurs when the growth hormone secretion occurs before closure of the epiphysis, which is before puberty is over, and they become giants. Here you see one of them. Look at the shoe size of this man compared to his brother, I believe. I had one case, a giant, in Cleveland, Ohio, and it was so unfortunate that we had to call the social worker actually to intervene, because his dad refused that his son gets surgery because he wanted him to play basketball, and he wanted him to become really tall and then have him play basketball. What he did not understand is they cannot play basketball. I mean, they have severe arthropathies, cardiac problems, and things like that. So we had to involve the social workers because his dad was hurting him. How do we diagnose it? If acromegaly is suspected, then you can measure IGF-1, and most of you answered that correctly. Why not screen by measuring growth hormone level? Because growth hormone changes, and there may be an overlap between a growth hormone level in a control and a growth hormone level in an acromegalic. Now, if it's extremely high and the patient has the manifestations of acromegaly, then yes, you can diagnose it based on that. But IGF-1 is the gold standard. An unequivocally elevated IGF-1 in a patient with typical clinical manifestations confirms the diagnosis. A normal IGF-1 is strong evidence that the patient does not have acromegaly, but some patients early on may have normal IGF-1, or some patients with certain diseases may have a falsely low IGF-1. So also patients with a little bit of a high IGF-1, that may be a laboratory error because the assays used to measure IGF-1 are so different to the point that you're better off confirming the diagnosis of acromegaly with oral glucose tolerance tests. So what are the conditions that may lower IGF-1? They include hypothyroidism, malnutrition, poorly controlled type 1 diabetes, and so on. So you cannot exclude completely acromegaly if IGF-1 is normal when the patient also has these diseases. And OGTT becomes the standard recommendation to the point that many societies say all patients with elevated IGF-1 in whom you suspect acromegaly, you need to do the OGTT. What's that? You give them 75 grams of glucose and you measure growth hormone at different time points. And normally, growth hormone levels should drop to below 1 microgram within 2 hours. And if it does, then that tells you that the patient does not have acromegaly. So acromegaly, if the patient does not suppress below 1, some people use a lower cutoff of 0.4. So if they suppress to below 0.4, they don't have acromegaly. If they suppress to below 1, but not less than 0.4, you may still want to monitor that patient. And here you see the result of the OGTT. Patients with acromegaly, look at their growth hormone after OGTT. It remains elevated. And patients who are normal, their growth hormone level goes down to really low readings. So once you found out that the patient has abnormal IGF-1, abnormal oral glucose tolerance test, the next step would be to localize the cause. And the cause, as we said, 98% is in the pituitary. And you have to keep in mind, if you have a normal pituitary, that the patient may have other causes. Typically, you may find a macroadenoma or a microadenoma causing acromegaly, but sometimes you may find hyperplasia of the whole pituitary gland. Look at this patient. There is no tumor, it's hyperplasia. So what do you think this patient has? No microadenoma, and the pituitary is diffusely enlarged. It's probably a GHRH secreting tumor. So I reviewed the literature here and found this nice study for patients with biochemically confirmed acromegaly, but they have normal pituitary gland on MRI. Why is that? Most likely the patient has one of the rare causes of acromegaly, which is GHRH secreting tumor, making the pituitary hyperplastic. And these patients, you could measure GHRH, the assay is available, and you could do imaging with octreotide scan and further imaging to detect that case. That is the patient that I just mentioned from Dubai who came to me, acromegalic. He brought his MRI done a few months ago, showing no microadenoma. I said, before I subject you to further evaluation, I will repeat the MRI. And I repeated the MRI, and again, no lesion seen in the pituitary. So he's coming to see me next week. I'm going to measure GHRH and do octreotide scan to see if he has GHRH secreting tumor. And those cases that I mentioned, 21 cases of GHRH secreting tumors, when they did the pituitary imaging, it was interpreted as pituitary enlargement without evidence of an adenoma in 8 of these 21. normal in 5 patients and suggestive of adenoma in 5 patients. So it may even, you may see something and you may think it's a pituitary adenoma. So you have to be careful in the patients who have family history of multiple endocrine neoplasia and things like that, previous tumors. You have to be very careful with that diagnosis. And you could do the GRH determination, as I mentioned. What are the goals for treatment of acromegaly? You need to manage the pituitary mass, you need to suppress growth hormone and IGF-1, and you need to prevent the long-term clinical sequelae of hypersomatotropism. And mortality in patients with acromegaly is higher than age-matched control, as you can see in this follow-up from New Zealand. You look at the survival, it's much lower in patients with acromegaly over the years. And the cause of death is mainly cardiovascular. Some of them also have pulmonary causes, and malignancy is higher in such patients. So symptomatic cardiac disease is present in 20%, and it's the major cause of morbidity and mortality. Hypertension is highly prevalent, and diabetes as well. The Endocrine Society practice guidelines recommend that all patients with acromegaly should be screened for associated comorbidities such as hypertension, diabetes, heart disease, osteoarthritis, and sleep apnea. Sleep apnea can be obstructive, but it may be also both central and obstructive. They also recommend managing their comorbidities longitudinally, and they suggest screening for colon cancer with colonoscopy at the time of diagnosis. They also suggest a thyroid ultrasound if you palpate any thyroid abnormality. The biochemical goals of therapy is to reach a normal IGF-1, and they also like growth hormone to be below 1, because that correlates with the control of acromegaly. The treatment modalities have improved over the years. In the old days, we had neurosurgery only, plus radiotherapy. More recently, dopamine agonists, somatostatin analogs, and pegvisomab, which is a growth hormone receptor antagonist. And the management is shown here. You try to remove the tumor first, and the most important thing is to identify a good pituitary surgeon. This is in 1550, operating on the brain, a painting actually on how they used to operate on the brain, not what they used to do with the patient. But fortunately, Harvey Cushing, the father of modern neurosurgery, simplified the whole process. Harvey Cushing was born in Cleveland, Ohio, and he lived all his life in Boston at Brigham and Women. And then he retired, went back to Cleveland, died there, and buried there. I had the honor of visiting his house in downtown Cleveland, as well as the cemetery where he was buried. And Cleveland is proud that Harvey Cushing was born there and died there, but Massachusetts always fight them and tell them he was born there, he was buried there, but he lived all his life in Boston and, obtained his fame in Boston, Massachusetts. So, but Cleveland had that stamp for Harvey Cushing. So surgical treatment, the efficacy is shown here, 80% for microadenoma, and unfortunately less than 50% for macro, and that's why you need to catch them early. Advantages: rapid onset, one-time cost. Disadvantages: hypopit and diabetes insipidus. And IGF-1 normalizes in around 50%. And complications are not that high in good hands. Dopamine agonists could be used, and the best response to dopamine agonists is in the patient with mild acromegaly. So I use them sometimes. I start with them, especially if you have mild acromegaly. Patients respond. 30% of the patients may actually respond to cabergoline, which is nice. Somatostatin analogs, we have two on the market, octreotide and liraglutide, which are used for acromegaly. There is a third one as well, pasitrotide. And they work by binding to the receptors in the pituitary or anywhere else, and they block the release of growth hormone. And we have octreotide LAR, 20 milligram monthly intramuscularly, and then you can titrate the dose up or down based on the response. Liraglutide is an autogel depot that the patient could actually use himself or herself and inject at home monthly instead of having to come to the hospital to inject. The efficacy controlling growth hormone in 65% of patients. As you know, this is after surgical failure, right? First you attempt surgery and then after surgical failure, you could use these medications. Pegvisomant is a growth hormone antagonist. It's a huge molecule. It's given subcutaneously, and the only problem with it is it does not affect the size of the tumor, so you may get, you have to monitor the tumor size. They're expensive. All of these medications are expensive, but efficacious. What about radiation therapy? Radiation therapy used to be done frequently in the past, much less now, but this is the recommendation of the Endocrine Society. If you have residual tumor that is big and medical therapy is unavailable or unsuccessful or not tolerated, then you could use it. There is the stereotactic radiation therapy and there is the conventional radiation therapy. They take time to work, of course. Efficacy in lowering growth hormone below 5 is 90%, but our target is below 1. And normal IGF-1 in only 24 to 54% of the patients. Advantages: permanent one-time cost, good compliance by patient. Disadvantages: hypopit and visual and CNS dysfunction. So, in summary, the management is transnodal surgery. If IGF-1 remains high or random growth hormone is above 1, then consider treatment with dopamine agonist. If that does not work, then somatostatin analog. If that does not work, pegvisomant. If still high, you could use combination therapy, dopamine agonist with somatostatin with pegvisomant. You could do that. If still high, use radiation therapy. And you could go to the Endocrine Society guidelines and see the algorithm for the management, or also there is another group, a consensus group that published similar guidelines. With that, I thank you very much for listening.